Hello, everybody. I am Dr. Steve Johnson. I want to welcome you to this series, REBT Masterclass, and this is episode 2. If you missed episode 1, I will, at the end of this webinar, I will give you a way to get access to that video for the first episode. Okay. Just wanted to, again, welcome all of you and and let you know that in this episode, I will probably not review much of what I did in the first one. I'll do very brief. And as I said, if you want the information that I covered in the first one, then just go to the site that I will mention at the very end of this webinar, and you can have access to everything you need that was in there. If during the this webinar you have comments, just put the comments up, and I will answer them as I can. So let's get started. Last time when we were looking at this, we were focusing in on the ABC model within REBT, which is the central model for the therapy. And remember, in that model, there are 3 components. Actually, there are a few more, but the ABCs I want to mention very briefly. The A is what we call the activating event, or some people call it the adversity. We like to zero in on something that's called the critical activating event. Activating event may be more general. So the critical activating event would be that part of the event or situation or state of affairs that is most relevant to the emotions and behaviors or even physiological responses that the clients are bringing in and upon which they want to work. So we will we'll try to get a very clear explication of what that critical activating event is. And so that would be the A. Let's go to the C. The C would be what we would call the consequences, not the consequences for the activating event, but consequences for something else that I'll mention in a moment. And those are what? Behaviors, emotions, physiological responses. So those would be the consequences. They are the consequence largely, but not totally, of the beliefs that we have. Now, in general, in REBT, we use the word belief, but often we're talking about 2 different kinds of cognitions. One would be inferences, and the other one would be beliefs. Remember, inferences are those cognitions that make an attribution of meaning to the event, situation, state of affairs. Okay? Whereas the beliefs do not make an attribution of meaning, but they are an evaluation, an assessment, an evaluation of the activating event, the critical activating event. And so we focus in REBT, we'll focus both on inferences and beliefs, and we try to identify both those kinds of cognitions when we're working with the client very early, particularly even in the first session, of course. And so what we will, but we focus more largely on the beliefs, the evaluations, because an individual could have one inference, right? And have many beliefs associated with that inference, and that would cause different emotions and different behaviors. So we would say maybe the inferences are maybe a distant cause, but the contiguous cause, the proximate cause, the cause that is closest to the emotions, behaviors, it's whatever would be those beliefs. So a lot of the action, a lot of the focus within REBT will be on the client's beliefs. Therapists should also be aware of their own beliefs vis-a-vis the client, those beliefs that they have about the client and what the client's talking about, in other models, more psychodynamically oriented models, they would call that countertransferential stuff. Okay, so let's zero in on emotions. I know I'm going really fast, but as I said, this is just a quick recap to jog our memories about what I covered last week. And if you need to go more in depth, which I did, you can go to the webinar from last week. And as I said, I'll tell you how to get that. When we look at emotions, we make some distinctions among emotions within this model. For example, positive emotions and negative emotions. Positive emotions are those emotions that we humans tend to like when we experience them. Happiness, calmness, contentment, those kinds of things. Joy. Negative emotions are those emotions we generally don't like. Those would include depression, anxiety, rage, hurt, guilt, shame, remorse, all of those. They don't feel good. And so we don't really like having them. But if we zero in on those negative emotions, because largely those are what are going to be brought into a session. I've never had a client come in and go, "Hey, doc, I'm just irrationally happy." And I'm like, "Okay, what's your secret so that I can borrow it?" Right? We divide negative emotions into a couple of things, a couple of types. There are those negative emotions that are helpful, and there are those negative emotions that are unhelpful to a large degree. And in a minute, I'll tell what is the discriminating factor to determine their helpfulness or their unhelpfulness. Because so many people just believe all emotions are helpful. Well, we don't approach it that way. And we will tend to sort them into helpful versus unhelpful based upon the outcomes of having those particular emotions. Okay. But some are helpful and some are unhelpful. How does that come into play within the therapy itself? Well, if clients come in and they have unhelpful negative emotions, we will work directly to try to change those. Helpful negative emotions, if they disturb themselves about helpful negative emotions, we will work with them so to help them see how adaptive those helpful negative emotions are. But we live in cultures today where a lot of people have helpful negative emotions, but they disturb themselves. For example, they're sad about something and they go, "I just can't stand this being sad." And so they take a helpful negative emotion, because nobody really likes to feel sad, and then they can make it dysfunctional. They make it unhelpful because their cognitions, their beliefs about that emotion are just not helpful. Okay. Um, Again, there's no judgment for that within REBT. We just want to help clients feel better, but more importantly, get better in their life in particular kinds of ways that I'll mention here in a minute. And one of those ways is a helpful negative emotion is one that an individual experiences. And while it doesn't feel good, it doesn't get in the way. It may actually help them to uh, carry out their desired life goals, short-term, long-term goals, right? Both kinds of goals are important, and we include both kinds of goals within our work with clients. Unhelpful negative emotions tend to sabotage or impede or get in the way of an individual obtaining their desired life goals. Okay. And so if a client reports an emotion, it is on our responsibility as the therapist to assess the functionality or dysfunctionality of that emotion vis-a-vis the client within whatever roles they're talking about, and whether that emotion helps them reach the goals within that role or not. Okay. So any questions about that, feel free to just hit me up with comments. Now I want to move to, in the ABC model, what we would call the D. Albert always liked to have simple ways. Albert Ellis, the founder of this model, always liked to have simple ways to help clients and clinicians. We all like something simple, but not overly simple. help them to remember and have a strategy and a kind of cognitive framework in which they can help themselves, because our goal is to help clients help themselves so that they don't rely upon us for long term. We want to get them out into the world and experience it and have do a better job of reaching their desired life goals without a lot of deep emotional pain or a string of failures in terms of obtaining those goals. And so what we do next in REBT, so take a step back. So when clients come in, they typically will come in with, in their presentation, an activating event. You'll never believe what just happened to me. You'll never believe what happened this week. Oh my gosh. So that would be an event. Or they come in with an unhelpful, emotion that's getting in the way, or some behaviors that are dysfunctional and just not helping them in the different domains of life, which could be personal, interpersonal, family relationships, occupational, academic, recreational, spiritual, whatever those domains are, those emotions and beliefs are not helping them. Okay. So the strategy within REBT will be, and this is a little different than the third wave models like DBT and acceptance and commitment therapy, although those third wave models and second wave model like REBT and CBT, there are more commonalities than there are differences. There are significant differences, but really they all focus on beliefs and emotions and behaviors, etc. Okay. So, and I like all of these models. I find them all helpful in different ways. Okay. So when we get the A, then we say, oh, when you were going through that, or when you experienced that event or situation, what emotion did you experience, or emotions, right? Or what did you do? So I'm asking about a C. I'm asking about their emotions or behaviors. Okay. So now I have the C. If they come in with the emotion, they go, I am really enraged. And we go, about what? What happened? So they gave me the C, and then I go to the A. Now remember, I have to assess the emotion in terms of its functionality or dysfunctionality, in terms of their reaching their goal within that particular role that they're talking about, within that domain of life. Once we have the beliefs, and we will ask them, what were you telling yourself? What were you thinking when you were in that situation and experience? And then you name the emotion that they presented with. Okay. And so what we're hoping is that we will get a belief. Sometimes we'll get a belief, sometimes we'll get an inference. I'll talk about that a little bit later if they give us an inference rather than a belief. But what we do if we have a belief is we challenge that belief for them. The goal there is to help them see that belief is not helpful for them, because many clients they think that their belief is just correct and that it reflects reality as it is, that there's no evaluation involved at all, and that they're right. And what we will focus on is the pragmatics of that belief. Is that belief helpful or not, right? If it's not helpful, then we will challenge it to help the client realize the dysfunctionality of that, or partial dysfunctionality of that. Now, how do we challenge someone's beliefs, right? Well, there are 4 general types of disputes that we use. I'm listing these in the order that we generally find more helpful to clients. This is not true for all the clients. We're listing them in general. And when we first are working with a client, we don't know which among these disputes or challenges of those beliefs is going to be most helpful for the client. So we probably will try all of these, and then we begin to see which one helps the client realize the dysfunctionality of that belief. We don't stop with them when we help them realize the dysfunctionality. We will go further than that, but this is a step, right? And the first one that most clients respond to pretty well are what we call the pragmatic or functional dispute. This is when, and we would say something like this as a therapist, and then you would put this in your own language, right? But don't deviate too much from the function here. The pragmatic or functional dispute, we would say, how is holding that belief helping you? So, for example, how is believing that you're an utter failure as a human being, right? How is that helping you? What do you get out of that? Tell me what good things you get out of that. And then also tell me what bad things you get out of that. Okay. So now they'll look at you a little funny. And so, because they don't normally think this way. And most of us don't think that way. We just think, this belief is right. It reflects reality. And what am I going to do? So most people want to go and change the A. Well, sometimes you can't change the A, especially if it's vis-a-vis another person and you don't have control over them, right? We're not God. And so we can't decide what they do or not do. We can hope, wish, want, desire, but we don't have any control over them. So we will ask them, how does holding that belief help you or not help you? Or what do you get out of that? Okay. Usually clients respond pretty well to that kind of a dispute. Now, the one that they most feel most helpful is the empirical one, right? So with the empirical one, we would ask, and where is the evidence for that belief? What evidence do you have that that belief is correct or reflects reality? And a lot of them will give you evidence, but the evidence they give is not relevant to the belief that they hold. So, for example, if I say, how is it, where's the evidence that you're a failure? And they go, well, I fail, I just fail at so many of my exams. And we go, okay, the most we can get out of that is that, there are numerous occasions in which you do fail. But to be a complete and utter failure, you would have to pretty much fail at everything, but you don't do that. And you're selecting these things to evaluate yourself globally as a failure when it's just a subset of all the hundreds and thousands of things that you do every day. So you see, we're helping them see that they're arbitrarily selecting something and then globally evaluating the self based on that subset of their behaviors. And another one is the friendship dispute. The only friendship dispute is very powerful, but we tend not to use that with clients that have anger. And anger is the big issue for them, or rage. Okay, so what we do here is we would ask them, if you had a friend who said that because they failed several exams that they're a complete and utter failure, what would you say to them? Okay, what would you say? Would you say to them, yeah, I've been meaning to tell you, I think you're a complete and utter failure. I don't even know why I have you as a friend. Why don't you just give up on life? And they look at me, they smile, and they say, no, of course I wouldn't say that. And I go, why not? Why wouldn't you say that to someone? Well, because it's not helpful. And then, is it helpful for you to say that to yourself then? You wouldn't say that to a friend, right? The same criteria of the universe apply to you as it does everyone else. But it seems like you're being harder on yourself in terms of evaluation than you are even for friends. Why would this not work with anger or someone who, is enraged a good amount of time? Because if you say, what would you say to a friend who said, that the boss firing them means that the boss is a complete and utter jerk? What would you say to them? And go, yeah, you're right. You're absolutely justified in feeling angry. But that's the problem with anger. Most people who have anger, particularly an anger issue that pops up frequently with intensity and across domains, and that lasts for a long time, frequency, intensity, and duration, we always look at vis-a-vis symptoms, then that would be an issue. The last dispute um, is the logical one. And we would say, how does it logically follow that because you want something to be a particular way, that it absolutely has to be that way? Is there any logicality to that at all? Most people don't respond to that one so much because most of us are not logical, right? We don't tend to think that way. We're not like Spock. However, um, you never know. There are some clients that just respond to that very, very well. Now, I had a question, and it frequently comes up, and that is, would these disputes tend to work with someone who is delusional? And that will be coming up in another episode where I will be looking at how we would use REBT with schizophrenia and other psychotic disorders. Our approach will be somewhat different, but that would get me off track today. But if you stay tuned for other episodes, I will be focusing on particular interventions for particular kind of DSM-5 diagnoses. For example, I'll definitely be looking at PTSD and other trauma-related disorders, as well as schizophrenia, and other psychotic disorders, right? Which are thought disorders. And so some people believe that the disputes won't work with them. That's not quite true. It does help, but we make some modification to it. So thank you so much for that question. And that is true even if they're actively delusional, okay, or hallucinatory. We can still work with them. Years ago, we thought we couldn't, but now we have developed interventions both within CBT and REBT to help those individuals who are in those populations. Okay, so good question. Okay, so these are the types of disputes. So once we get the A, the C, and we get the B, right, then we would dispute it to help the client realize the dysfunctionality or unhelpfulness of that belief. We would initially try all of these. And then over time, we realize that some of these work better for the client than others, okay? Initially, try everything, and then zero in. Now, those are the types of disputes. But then there are also styles of disputing. And this is equally important. Each of those that I just gave, the pragmatic or functional, the empirical, friendship, and logical, can be done with different styles. And we generally like to begin with most clients the Socratic style. That's where we ask them questions. And that's what I just demonstrated with the last one, right? So for example, someone who says that they're an utter failure because they failed several exams, which would be some of my students who would be thinking that. I'm like, oh no, don't do this to yourself, because then you make it even more difficult to do better within the course and within your career, etc. So we would ask the questions: how is that helpful, right? Where's the evidence? What would you say to a friend? Those are open-ended questions. Okay, why would we start with that? Because Socratic questions help get better engagement from our clients. They're more actively involved. And it's much more, we know from common factors research, that if we're actively working with them, collaboratively working with them, the outcome tends to go better. We have no guarantees of any outcome, right? We can hope for an outcome, but we can't make it happen because we're working with people with relatively free will, right? So if they're not responding to the Socratic, right? And this would be true for clients who tend to be more concrete than not. I mean, no judgment. Some people are just more concrete, more like open-mindedness, open kind of approach to things. In didactic, it would be more teaching. So, for example, if the irrational belief or unhelpful belief was, I am an utter failure because I failed several exams, we would say, and they didn't respond to the Socratic, they couldn't come up with any. Then we would say, some people who have failed, a number of exams, tend to begin to think in this way. And are you tending to think in this way? But keep it vague, because especially, and I know a lot of people think that we're putting words in their mouth, and we always preface this with, if I'm off, please let me know. You have to make an assessment on the level of dependence of the client. Someone has a dependent personality disorder, you got to be really careful, right? Otherwise, they'll just agree with you and then say it didn't work. And so we use the didactic after the Socratic, but even there, we will state it pretty loosely as some people in that situation, not everyone, but some people in that situation may think that. Is that anywhere close to what you are thinking or not? And if not, let's discuss this a little more. See what I mean? Keep it open. Don't go, I know exactly what you're thinking. You don't. Metaphorical. This is sometimes we will tell a story. And metaphors often are really good. Now, I know in logic, a metaphorical dispute is considered the lowest level, but if it works with clients, we will tend to use it. So, for example, I've had some conservative or evangelical Christians who are engaging in anxiety. They have a lot of anxiety and then anger too. So sometimes I will give them the story of Jonah, right? Remember, the story goes that Jonah got a kind of an order from God to go to Nineveh and preach against these people that they're not being good, right? And it's not a great story. They don't tell you in the story that the Ninevites were the traditional enemies of the Jews, and so it's not a great assignment. So he's anxious about having to go in the middle. So what does he do? Well, we know from REBT, and we talked about this last week, that the behavior that is largely associated with anxiety is avoidance. And that's what happens. He avoids. He hops on a ship to go somewhere else, and then he's thrown overboard. So it's a clear example of the dysfunctionality of anxiety. And then later in the story, he has some anger, and so we can talk about that, right? So those kind of metaphors, those kinds of stories can be really helpful. And sometimes they're examples from movies or just stories that they like or whatever, right? So we can begin to incorporate those in that style of the disputes. And then another one, and this one we need to be very, very cautious with, and that is the humorous style. Do not do this real early with a client. You really need to get to know the client a bit, and to kind of get a sense for what their level of humor is. And if they tend not to be humorous at all, they're very, very serious, then you're probably not going to do this. Or be very careful if they come from a different culture, because humor can be, kind of culturally grounded. I know I traveled around the world, working with REBT and training people, etc. And what I have found is sometimes what's humorous, among my friends here in the United States just falls flat there, or they'll tell me their humor. And I'm like, I don't get it. So just be aware that there may be cultural differences and take that into account. And when you use humor, don't use it against them. Talk about the humorousness of, what happened or something like that, but never use it as a way to attack them. That's never acceptable at any point with any form of psychotherapy. If you're going to attack clients, go into a different profession, okay? So we wouldn't want to do that. Okay. If there are no questions, I will move on. Let me give some examples here. Let's say, and I have one like this, is I am stupid because I failed my final exam in REBT. There are different types of disputes. So remember, I could do the pragmatic or the functional. I could do the empirical. Pragmatic would be, how is it helpful for you to call yourself stupid because you failed the final exam? Are you getting something good out of that? What is there any bad that comes? You see what I mean? So we try to get some explication of that. Or if it's empirical, where's the evidence that you are complete and utterly stupid because you failed an exam? Is everybody in the world who failed an exam utterly stupid? So many, very successful people in life have failed at things. Does that make a complete and utter failure? So you see there, we're looking at an empirical dispute. Or what would you say to a friend, a friendship dispute? What would you say to a friend who failed the final exam in REBT? Would you say that they're completely stupid? They might say, no, I wouldn't say that. It's not helpful. And it's not, because maybe that's not, maybe they just didn't get that. That some courses are more difficult than other courses for people. Just what we're interested in and what comes easily for us, etc. Doesn't mean you're stupid. The most you can say is you failed an exam. That's the most you can conclude of failing the final exam in REBT. And then logically, how does it logically follow that because you didn't want to fail the exam, that you absolutely shouldn't have failed it? I think there's evidence to the contrary. What is it? You failed. If you fail an exam, you have to fail the exam. That's just what happened, okay? So you see, that's a little more difficult for people to get, but some people respond to that really, really well. Try them all. And so what we want to do is this. Once we have challenged those beliefs, we don't just stop there. Okay, now I realize my belief was dysfunctional. What do I do? So part of what we will help them do is replace that. This is all called cognitive restructuring, where we identify, we challenge, and replace the dysfunctional belief with the more functional, helpful belief, okay? Now, last week, I covered what rational or helpful alternatives to the dysfunctional beliefs would be. Now, remember, we had 4 categories of dysfunctional beliefs within REBT. CBT has a longer list. We have just 4 types, but they cover all the ones that CBT does. CBT, if you look at the list of CBT beliefs, they include what in REBT would be both inferences and beliefs. It's just how you slice the pie. The models are essentially the same on this, okay? So remember, the core dysfunctional belief within REBT is demandingness. When we make demands on what? Self, others, life, and the world. When we make demands on it, since we're not in charge of any of those, then and things don't go according to our demand, we set ourselves up for potential mental and emotional kinds of dysfunctionality. Not invariably, but we set ourselves up for it. Excuse me. So what do we put in the place of demand? We put preferential beliefs, wishes, wants, hopes, desires, right? Because and you can strongly wish or want or hope, but that is qualitatively different from a demand. It has to be this way. It must be. I must be this way. You must be this way, right? Because if we're demanding and reality doesn't correspond, then we tend to disturb ourselves. But if it's a desire and we don't get the desire, we may be disappointed, but we're not as catastrophically upset as we would if we are highly demanding. Now, clients will, some of my students will say, does that mean you can't use these words? Well, we use those words, should, ought, must, have to, need, but most of the time when we're using those words, we're not being demanding. So we need to talk to the client when we hear that kind of those words to determine whether they're really being a demand, whether they're really being demanding or not. If I say, this subway should not have flooded, I'm not demanding that it wouldn't happen. I'm just saying, man, they could have done a better job or something else, So I'm not really getting, getting it. Okay. So someone just said, is anger the result of not getting what we need? Not necessarily. Some people, sometimes it's not about a need, it's about a want. And if they don't get what they want, then then they can get upset. So just because they get angry doesn't mean that some need was violated, because we often confuse needs and wants, and unfortunately, psychotherapists can reinforce that problem, right? By using phrases like that. If you get angry, that means something that you didn't get. Wait a minute. If we help them realize that what they think they need is actually a want and treat it as a desire rather than a need, that may give them more help in life. So thanks for that question. It was really, really helpful. And so the rational alternative would be preferential language. The second kind of unhelpful belief or irrational belief that we discussed last week was awfulizing, or in CBT they would call it catastrophizing. That's when we believe about something that it's terrible, it's horrible, it's awful, etc., or similar language. And again, sometimes we use that language, but we don't mean that it is 100% as bad as it could be. But if we're truly awfulizing or catastrophizing, we are believing that it is 100% as bad as it could be. So we check that out with the client, okay? And determine whether it's an irrational belief or it's just a rhetorical flourish, and just the word we use in those situations. Okay? I might say, if I'm in the traffic and I'm going to go, it's horrible. I'm not saying that it is the 100% as bad as it is, even if it's not moving very, very, very quickly. Okay. But I may say that because there it's not expressing belief so much as what we call the expressive evocative use of language. It's just, we're just venting emotionally, but we're not really believing that state of affairs is truly awful or horrible or a catastrophe. If we do, then we do set ourselves up for disturbance. Does that mean that there's an emotional problem with the individual? No, that's just human. Humans do this all the time, right? But if they do it repeatedly and that becomes a theme in their life, then they are setting themselves up for some disturbance, okay, more than they probably need to go through. So what do we do instead of awfulizing? We accept the badness of the situation, right? But realize that it could be worse. This could be worse. I remember when I got cancer, and initially I'm like, oh my gosh, this is a catastrophe. And I really believed it, for a few days. And then I realized, my life could be worse. I could have cancer. My family could just be under attack. That I had, and I have no friends whatsoever. When I'm believing that it's 100% as bad as it is, I often forget the real resources, or what some of my friends would call blessings, that exist within their lives, and that's not helpful. But, when we get news like that, we're not going to be our most rational self. So we're kind and gentle and kind of accept ourselves, and we help clients accept themselves and help them get back on track to realize that this event is not 100% definitive of the value of your life and nature. Okay, so it's really, really important that we can help them with that, but we probably don't go after that real soon when someone gets some negative things like that. Let me give you a case. I had years and years ago a case in which two parents came in to see me, and they were both significantly depressed. And they had a 2-year-old, beautiful little 2-year-old girl. And they were at a pool party, and the little girl, someone left the gate open to the pool. She got in, no one saw her, and she drowned. And so, of course, they're just devastated. I am not going to say to them, is this truly 100% awful? If I say something like that, they should take my license away, right? Because it is utterly is lacking in empathy. And so we would never say something like that. We hope over time that they will come to realize that while this is a huge tragedy, their life does, have some meaning and purpose, etc. And that may take a while, and it'll take whatever time it takes. We can help them in a different way with those situations, but I'll talk about that when I get to grief. Okay. Um, what about frustration and tolerance? That's what Miller calls, I can't stand it at itis. This is too much. It's overwhelming. I can't handle. Clients will often say that because that's just a prototypical belief associated with anxiety. Okay. And so, of course, the counterexample is they're standing it as they're saying it. They just believe that, but that they, at some level, they know that's not the truth. They are standing it. And so if we help them realize the ways in which they're standing it, right? Or, is it helpful to believe that you utterly can't stand something, etc., then we're getting them on a better track. So what would we want to put in its place? What would be the rational or helpful alternative to frustration and tolerance? It would be, again, accepting the dissatisfaction of this state of affairs, but realizing that they're standing it. They may not be standing it in their A game, but they're getting through it. They haven't collapsed. No one's having to give them mouth-to-mouth resuscitation, but when they believe that they can't stand it, they're kind of escalating that up. So what we want to put in its place is just that. Recognize that this is not preferable. You don't want it. You wouldn't wish it on anybody, okay? But you're standing it, okay? And then last would be what we would call global negative evaluation. And the emphasis here is on global. Global negative evaluation of what? Self, others, life, and world. And so the global evaluation of the self would be, I'm a loser, I'm a failure, I'm no good, I'm beyond hope, I'm beyond redemption, all of that kind of nonsense. We all believe that at times. That's just human. But it's not helpful when we do that. And so what we want to do instead of that is unconditional self-acceptance. People really get confused about that, and I will cover unconditional self-acceptance in a few minutes. But unconditional self-acceptance says, you know what? I mess up at things. I'm a fallible human being that sometimes I just act up in screwy ways, okay? We accept that. Okay? We don't like it. But you know what? If we accept it, if we accept ourselves, we are more resilient and we are more likely to be able to have the reserve and the grit to make changes. If you put yourself down, globally rate yourself, you make yourself feel so bad, you don't have, that you need to move on in life. Because my specialty is trauma and addictions. So if we look at someone who has an addiction, let's say alcohol, okay? And so they go, I'm not going to drink, and they're very serious about it. I'm really happy. I'm not going to drink, I'm not going to drink. And then they drink. And then they just beat themselves up. They go, I'm always doing this. I'm a failure. I've let my family down. How many times have they gone through this? I'm just no good. And they beat themselves up and they beat themselves up and they beat themselves up till they make themselves feel so bad. And then the thought will come into their head. There's one thing that always makes me feel better. And guess what that is? To drink. So often when I'm working with clients with addictions, I'm like, let's catch this. If you're starting to globally rate yourself, let's catch this very early, because that will be the next step into you acting out in ways that won't be helpful for you, okay? And once they get that, then they can unconditionally accept themselves. They go, I wish I hadn't done that. I really wish I had done that. But then they shift the focus, not on beating up on the self as what can I do differently? What can I learn from falling off the wagon? Okay? Treat it as a learning experience rather than as an opportunity to waste your time beating the self up. Same way with others. Instead of say they're a loser and a failure, etc., is unconditionally accept them. Not necessarily like what they do. And you may choose not even be into relationship with them if you don't. But you unconditionally accept that's the way they are right now. Okay. And the world, if we go, the world should not be this way. The world is nothing but a veil of tears. Da, 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 da. Then we really, then we become worried. We often, if that goes on for a while, we have to do a suicide watch, right? Or unconditional acceptance of their life. They think my life is no good, it's not worth living. Again, those are very serious kinds of beliefs. So we want to get them to an acceptance of their life, realize that there are some things about their life that may not be good. They may be really bad, but nothing is irreversible, right? And so, or even if they have a terminal illness, right? Then we can help clients find meaning and purpose in the midst of the life that they have left. So, so unconditional acceptance is there. A lot of people think unconditional acceptance means that you won't do anything to change it. No, actually, if you unconditionally accept something, you're more likely to be able to change it because you have the emotional energy to do it, rather than beat up on the self and convince yourself that you're worthless. You can't, there's nothing you can do that's help. We see this in depression. The helplessness and the hopelessness of depression is because of the global negative evaluation of the self. And that's why in depression, we really want to help move those clients away from that global negative rating. Okay. Hope that's clear. Not, feel free to ask a question and we'll address that. So back a few minutes ago, remember when I said when a client brings in a particular situation about which they're upset, or they bring in an emotion or behavior that is a bit dysfunctional and they're not liking it, it's not getting them happiness or not helping them in the goal attainment, in whatever role they're interested in, then what we will ask them, what were you thinking? What were you telling yourself? We've got the A, we got the C, and then we want to get to the B. We say, what were you thinking in that situation that caused that? And then you name the emotion or the behavior. And they may give you an inference. Well, we need a belief. The inference is helpful. That the inference will tell us what meaning they're giving into the situations. And at another time in the next episode 3, I'm going to be talking about what do we do with those inferences. They're important because those are the meaning that we give to the world, and people can give very negative meaning that is highly dysfunctional. Okay. But today I want to focus on those cognitions that are contiguous, that are more near to the emotions and behaviors. And so those are beliefs. So if they give us an inference, we want to find a way to move from the inference to the belief. Okay? Let me say that again. When I'm asking, I've got the A, I've got the C, I want to get to the B. I'm asking them, what are they thinking? What are they telling themselves? And they give me an inference in terms of the response. Then what I want to get to the belief. Let me give an example. Let's say someone is depressed, and the inference that they have is, because they lost their job and they're depressed. And I said, what were you telling yourself? And they say, oh, I'm not going to be able to get another good job. Well, that's not a belief. That's not a demand. It's not awfulizing or catastrophizing. It's not frustration. It's also not a global negative rating. It is the meaning that they're giving to losing that job. The meaning they give to it is that they'll never get another one, never get another good job. That's the meaning. Now, that's not a helpful meaning, and that's going to get in the way. But what I want to do is work with the belief, because the belief will be closer to the depression than that inference will, right? You could hold that inference and not be depressed, but the beliefs that you hold vis-a-vis that inference can cause a depression. So we do something that's called an inference chain. Inference chaining is a technique that we use within REBT. When clients give us an inference and we want to get to a belief, And we use this to try to get to the belief. It takes some finesse. So let's look at that. If my students are on here, just know that it's coming up in a few weeks. So we'll get to this in very, very, very clear ways. Here's how we do an inference chain. The form is, again, let's say the situation is I failed an REBT final exam and I'm feeling depressed. The therapist would ask something like this. What did you tell yourself about failing that final exam that has you feel depressed? Okay. Notice what we did. We put the A in there and we put the emotion in there. You have to put both of them in there. If you don't put both of them in there, you're not going to get a response that's going to be really helpful. Okay. What did you tell yourself about failing the final exam that has you feel depressed? Okay. The client might respond, I will never be able to become an effective counselor. Well, that's not a belief. That's an inference, right? And until you get some experience identifying and discerning between inference and a belief, the way to check it is very simple. Is that thought, I will never be able to become an effective counselor? Is that a form of demand? Nope. There's no demand in there at all. Are they saying that it's awful or a catastrophe? Nope. In that sentence, there's nothing that says that. You may say, well, they may be assuming it. You can't go on what you are assuming about a client. You have to go with what they say. Okay. Otherwise, you are imposing or projecting upon them. And that's never a good idea with clients. Or I will never be able to become an effective counselor. Is that a form of frustration and tolerance? No, they're not saying that they can't stand that thought, that it's intolerable or that it's overwhelming. If they did, then it would be frustration and tolerance. But in there's no frustration and tolerance. And you go, but they might have. Yeah, they might, but they didn't say it, right? And you can assume that they have it. So be careful that you're not imposing beliefs upon a client. Or is that a global negative evaluation of themselves? No. Or others? No. Life? No. The world? No. Okay. If they said, I will never be able to become an effective counselor and the world will be utterly devoid of meaning, okay, now we've got a belief, okay? But they didn't say anything like that. So once we have this inference, then we kick into what we call the inference chain. And so what do we do in an inference chain? You assume the truthfulness of the inference. That's important. You assume the truthfulness of the inference, which often for the client will be the worst case scenario. Okay? We go with worst case scenarios. Why do we go with worst case scenarios? Because if we can help them with the worst case scenario, we can help them with everything else that's not a worst case. So we go with the inference. We say, let's say that's true. So here's what the therapist might say. Let's say that you don't become an effective counselor. What would you say to yourself about that which would cause you to feel depressed? Notice, first is let's assume it. Let's say that you don't become an effective counselor. That's the worst case for them. And then what do you say to yourself about that would cause you to feel depressed, right? So then we said, what are you thinking about that situation? And then the emotion. So you got to get all those pieces in. Assume the truthfulness of the inference, whether it's truthful or not, because it's a worst case, and you're thinking it. And then what would you be telling yourself about A that's causing you to feel or experience C? Every one of those pieces has to be. Leave one out, you kind of mess up. And we will have more time in another real case next week to walk through this concretely. I'm giving you skills right now. So what if the client says, I would tell myself that I'm stupid and never getting a satisfying job that I would like? Okay. Now, this is two beliefs that are not helpful. One, I'm stupid, which is a global negative self-evaluation. The other, I'll never get a job that I like. Okay, that's a global negative evaluation there. So you see that just by forming it in the way that I did, I helped move them from the inference to the belief. Now you're going to have to practice. And my students, the ones who are on here, know this is true for all therapy. You have to practice, practice, practice. I assume my students will have some trouble with that, and so they'll get practice over and over and over again throughout the course so that they get some skills so that this will become a habit. We want them to habituate this skill, right? And in the beginning, they'll think about it, and later they won't have to think about it so much. I always say that REBT and second wave models do the reverse of what Freud did in psychoanalysis. Psychoanalysis is trying to take that which is unconscious and make it conscious. In REBT, we're trying to make that which is conscious unconscious. So you consciously have to think about doing that. We really would like for it to become unconscious, which means habitual, and you don't have to sit down and think about that. Kind of like brushing your teeth, right? When you're young, it was conscious, and now it's kind of unconscious. You don't have to think about it. You just go through the motions, etc. It's habituated. Okay. That's what this will become habituated if you practice, practice, practice. What if the client, though, responds with another inference rather than a belief? Well, just what we did. We will assume the worst case is projected by the client. We'll assume that their inference is true, and then we'll ask them what the client would say about themselves or believe about themselves that would cause a dysfunctional emotion. And we would hope for a belief. But if not, you continue the chaining. Now, you don't want to go on ad infinitum, right? Notice in the inference chaining, we're taking a Socratic approach. But for concrete thinkers, sometimes that were more concrete, then we have to shift into a different way. So we would say, well, some people in this situation may be thinking this. See, we shifted from Socratic to didactic, because they don't know what we're getting after, right? And so if we just keep doing the same thing over, they're going, I thought I told you, why are you not getting it? The point is not to frustrate our client. The point is to try to help them move from the inference to the belief so that we can actually change that dysfunctional belief to a more functional one after we have disputed it. Okay, I hope that's pretty clear. Now I want to cover some REBT interventions. Okay, these are things that we do, and I really have very little time. I will spend a couple of the sessions really digging deep into the interventions, and I will even ask some people to volunteer, and I can even demonstrate how to do it. There are three categories of interventions: cognitive interventions, behavioral interventions, and emotive interventions. Okay, and I want to give you at least one example of each of those before we quit the day. Here's some examples of cognitive interventions. One would be cognitive restructuring. Okay, we've already demonstrated cognitive restructuring. Identify the dysfunctional belief, challenging it through disputing, and then replace it with a more functional adaptive one. Okay, you already know that intervention, and that's a common one, and we frequently do that over and over, throughout therapy. Another one that is I just love doing and can be very, very helpful, not only as intervention, but as also as a diagnostic tool. Okay, and that's called rational role reversal. We don't do this initially. This is after we get to know the client a little bit. We know some of their beliefs and how they justify their beliefs and hold on to dysfunctional beliefs, that kind of thing, right? And so in the rational role reversal, we will explain that what we're doing is I, the therapist, will assume the role of the client when the client is being their most, they're engaging in the most unhelpful thinking that they may engage in sometimes. And we say to the client, we want you to be your most rational self, your most helpful self to yourself, okay? And then we might start by, let's say, for example, I might, as the therapist, I might say, I just failed my REBT final exam. I'm such a loser. And then the client might say, well, you're not a total loser. You failed the exam. Maybe you didn't study well. Maybe the professor just chose this question that was not really what he or she was focusing on throughout the course. And then I went, no, but I should have known anyway. You know what I mean? So I'm being demanding to myself. We go back and forth and back and forth. Now, I said it may be a diagnostic tool. Sometimes what happens, and this is rather frequent, the client can't respond to me being their kind of most unhelpful or irrational self, or at least believing those beliefs. Often they can't dispute it. They can't respond because they actually believe it. And so if that happens, we stop right there and we talk about the degree to which they believe that belief and how that gets them stuck or how that doesn't help them, right? And so we can use that as diagnostic, more clarification on the form that their unhelpful or irrational belief takes, and then we can do some cognitive restructuring around that. So I use this frequently. Clients usually find a lot of fun because they love seeing the therapist. What you do not want to do is have the client take the irrational role and we take the rational role. No, no, no. We don't want them practicing holding their unhelpful beliefs. They already have those down to a fine art. So we do not want them practicing that. So what we do is we take the irrational role, they take the rational role. Now, there's a technique and a sheet that I often give to my clients. If you're interested in it, let me know, and I will post that next week. It's called the zigzag technique. And we give the zigzag sheet to the clients, and they can use this between sessions when we are not there to do this rational role reversal. So these are examples of two cognitive interventions. Another one that's more behavioral, and this goes way, way back to the 1800s. And then it came out of different forms of therapy, and then Albert Ellis began to use it too, and that is acting as if. So let's say someone, again, is very, very anxious, and it prevents them from doing things that they would like to do, right? Let's say the family wants to go for a walk, and hiking, and the person is, I'm going to do that, they're more like me. I mean, I'm not going to go for a hike if I think there are wild animals out there. They're going to bite me, because I'm really irrational. I get anxious about that kind of stuff. Like snakes, I freak out about it. So what we do is we say to the client, let's act as if you didn't have the anxiety. What would you be doing that you're not doing? Now notice we're focusing on behavior. There's another intervention that's related to this that comes from solution-focused therapy, a therapy that I dearly love. And they call it the magic wand or the crystal ball technique. And for example, they would say to the person who's anxious, they might say, what if when you went to bed tonight, there was a miracle, right? Someone waved the magic wand, or a prayer was answered, or a miracle happened, and you woke up and you were not feeling anxious at all. What are 3 things that you would do that you don't do when you're anxious? They just gave themselves their homework assignment and their specific behaviors. Ask for behaviors. Act as if. Example, I had a group that I was running for young men, wonderful young men about high school age, who wanted a social skills group. The person who was going to do it couldn't do it, and so I said, okay, I'll do it. And these individuals had autism, on the autism spectrum. And so we were looking at, I was kind of trying to figure out a behavior that I could help them with, because I wanted to use a behavioral intervention more than a cognitive intervention initially. And so we found out that they had a prom that's coming up, and they all wanted to go to the prom. But they had never had a date. They never asked a young lady out for a date, or a young man out for a date. And so, although these were all young men, and so we were like, I was like, okay. So I said, well, what would you do? And so one said he was really into cameras. He like fixated on cameras, and he said, I would go up and ask them if they want me to give them a lecture on the inner workings of the camera. And so I said, this is going to take a very special woman, right, who's going to be interested in that. But I said, I love that you're brainstorming about this. This is perfect. And the other one said, dude, you're stupid. Everybody knows that girls like magic. And so you do a magic trick. And so we had a discussion about that might work, but for a good number, it may not work. And so we really brainstorm, and then we practice acting as if. And so I said, who would be, if you've seen a movie, who would be a guy who would not have trouble? He wouldn't be anxious about asking a young lady out. And they identified Ryan Gosling. Well, I didn't know who Ryan was, so I had to go watch a movie, and I went, yep, that dude would be able to do that. And so we practiced acting as if. Had so much fun in the group. And the good thing was all of them ended up getting a date for the prom. They didn't get a second date, but they were so happy about that they were just so excited for 3 weeks, and we're looking forward to practicing this again. So this is very common. Act as if you had courage. Act as if, right? Now, this is not the full therapy. This is one intervention in it, and it would help people move. And this is especially good for anxiety, fear. Fear and anxiety are essentially the same. Freud thought of them as different. He thought that fear had a discernible focus and that anxiety was more diffuse. Not necessarily true. We have social phobias. We have particular phobias. So we don't conceptualize it in the way Freud did anymore. And so, but it needs to be very specific, acting as if. Some people say, well, aren't you asking them to believe that there's somebody else? No, every one of these guys knew that they were not Ryan Gosling. There's no problem with this. They're acting as if in this situation to give some what we would call behavioral momentum to move in a different direction than they tend to do, which would be avoidance. We want the treatment for anxiety is to move beyond the avoidance. So we would often call that exposure therapy. This would be a form of exposure. Okay. Then, so that's a good one, not all of them. And so we have acting as if. Now, Alfred Adler was really good in Adlerian therapy about doing that. And then Dr. Peacock and myself work with populations that often have problems of anxiety and engage in high avoidance. So what we are helping them do is to act into their vision of the best version of themselves and take on challenges rather than avoiding them. Notice, take on challenges, especially if they're seeing them as overwhelming. So we have them try to reduce what they see as overwhelming to that which is a challenge and obtainable. So we act as if having them do that, right? And one is to have them act as if they had already become the best version of themselves, best version according to that client, right? And then to focus on concrete behaviors and strive to reach those short-term goals. What we know from research on this is that if clients strive to reach those short-term goals, what happens is dopamine raises, so we see the activation of the nucleus accumbens, which is really important. When dopamine is produced, that functions as motivation for them. So actually, we get more dopamine when we strive to reach the short-term goal than we get when we obtain the goal. So we want to help them get in there and strive to continue to reach the short-term goals, celebrate the attainment, and then we also have the long-term goals. But I will be looking at long-term and short-term goals a bit later, talking about the neuropsychology of them that we bring into the session, because a lot of times, particularly those of us who are professors for master's level therapists, but this should be different when we're doing doctoral level, but sometimes master's level therapists, we don't do a great job of introducing the neuropsych basis of that, what's going on in the brain, and to help them realize that if you move in this direction in terms of your intervention, you are making the process easier for the client because you're raising dopamine or you're raising oxytocin, which will get them to become more affiliative and connecting with others. Okay. So that's why I like to introduce that. So, master's level therapists, doctoral level therapists, they are grounding what they're doing in the way that the brain functions. Okay. So, example of emotive intervention. One of the emotive interventions that Albert Ellis made really popular is what he calls a shame attack. Um, and you have to be selective when you do the shame attack, and you have to prepare the client for a shame attack. A shame attack is when we have a client do something that they would normally avoid. So often it's, again, helpful for anxiety, but also for depression. And so, because there's withdrawal within depression, not so much avoidance, but withdrawal from those things that were rewarding in their life. And so we would, the shame attacks, you would have them do something that they would normally not do. Nothing illegal, nothing that would get them arrested, nothing that would cause shame upon them in the views of other people and hurt them on the job or anything like that. Absolutely nothing like that. Some examples in REBT is when I was at the Albert Ellis Institute there in Manhattan, we were just a block or two away from the southern tip of Central Park. So sometimes we would have clients go over, we'd talk about this, prepare them for it. This is really kind of a form of exposure therapy too. And we might have them do something like put a banana on a leash and walk it in Central Park. And so they go, well, won't people think I'm a little weird? Yeah, but it's New York, right? Nobody cares. When I was in Romania, we had them do a similar kind of thing. It wasn't walking a banana. And we got them out of their shell. It was really helpful. And then at the Ellis Institute, those of us who were fellows, we already had our doctorates and we were working on this kind of a model with other models. We would do one. And so I did, my shame attack was in New York, we have these delis on the corner, and you go in and there's usually like a buffet. It's not as long as you see buffets in big restaurants, but it's nice. I mean, some really nice food with salads and pasta and meat and all those kinds of things. And so you could get different size of containers. And so what I did is I got a big container, right? And so the big container, and I put two grapes in it, and I took it up, and then they weigh it, and then they charge you. When they weighed it, I said, and I need a knife and a fork with that. And I'm like, oh my gosh, you're going to think I'm so stupid. I can't do this. I did it, and they didn't bat an eye. In fact, one time when I did it, because I did it several times, they just started laughing. They said, is this a joke or something? I said, no. It's it's an assignment for a therapist. And they went, I love it. I think I'm going to start doing that myself. Or you go into a high-end restaurant and order a glass of ice water, something like that. Nothing illegal, is not going to get you arrested or anything like that. Okay. I've had people go on the subway and they yell out the stops, 42nd Street, Fifth Avenue, those kinds of things. So someone said mentoring and coaching to help them come to a reasonable choice. Yeah, we're going to talk about it and the possible ramifications for each of these, right? We don't just stick them out there. We always prepare them for what we'll go through. But too often, people with clients who are anxious try to calm them down when that's not going to help. What we want to do is have them experience the anxiety and learn how to begin to think in different ways so that anxiety is not maintained. The more we avoid, the longer they stay anxious, okay? Because when you avoid, you're building up how big the mountain is that you think you have to climb, when we want to show that the mountain is small for them, okay? Smaller than what they're thinking. So shame attack is a really common one. I want to give you one intervention because most of you are going to have clients that beat up on the self, right? Take an emotion. Um, Most emotions will have clients beating up on themselves in some way. Relational things, people they beat up on themselves for what they think are huge, unforgivable mistakes, etc. Okay, or actions. So this is one that my good friend, the late James McMahon, and I developed within rational motive therapy. Um, and this is to help clients separate the self from the roles and behaviors that they have. Because when people globalize rating the self, that never goes anywhere good. Okay. We really want to try to help them transcend the global negative rating of the self. So what we rather do, we just draw the self, and this is like a handout, a sheet that I would give my clients. And I would say, here's the self. Do not rate the self. Just let it do what a self is supposed to do. And what is that? It's selfing. That's what we want ourselves to do. Just be there in self. And then what we want you to do is over at the side, I want you to draw some lines. And now notice some of these lines are closer to that circle that has the self in it, and some are farther away. We do that in terms of our different roles. Those roles that are most important to you, you have them close to the self. Roles that are not so important to you, you have farther away. So me, probably the role that's most important to me is the father of my two daughters, right? If I make a mistake there, I say something unhelpful there, then I have a tendency to beat up on myself, okay? And feel really, really guilty and bad. And then there's some that, what would be another role that I have the role of professor. Okay, let's say I say something stupid. I'm not going to beat up on myself as much as I would beat up on this, if I made a mistake in the role of a father, because I just don't care as much for that role as I do being a father, okay, or a husband. Or even more than that, even being a son to my mother, who's 95 right now, very important role. So, but I also have a role of subscriber to, say, the New York Times. Okay, if I leave the New York Times out and it rains on it, I'm not going to beat up on myself. I'm just out some money. So we have the clients do this, put the roles in terms of order of importance, and then what we say is think about the goals that you have within your role, right? I have goals that I have as a father. I have goals that I have as a professor. I have goals that I have as a husband. I have goals that I have as a son. I have goals that I have as a member of my particular religious group. I have goals, I have all of these within my role. And what we want to do is look at your behavior that you've engaged in. And is that behavior helping you move toward your goal or not helping you? Evaluate that. Don't evaluate the self based on it. Just evaluate your performance, helping you reach the goal or not helping you reach the goal. And then we can together brainstorm, or you brainstorm and bring it in and we talk it over, how we might modify that behavior. Okay. Maybe it was because you had some beliefs during that moment, or you need some certain kind of skill that would help you move there. So that would help us get the kinds of things that we would need to focus on within the therapy. I can't remember a client that I didn't use this with, right? Now, this is true for people who rate themselves very, very high, right? A lot of people think if you rate yourself high, you're going to be much more functional. And that's not true. When research is done, we find that the group that has the highest self-esteem are prisoners, okay? But look where they are. Now, we don't want them to beat up on themselves, but self-esteem is not the issue we're talking about here. Self-esteem often will be to rate the self. We don't want to rate the self. We want to rate the behaviors within a particular role and accept the self. So that's a slight distinction. If you have a different view of self-esteem other than rating the self, well, then hold on to that, but so long as it includes unconditional self-acceptance, because then it's moving in a better direction. Okay. So if they rate themselves as really, really high, there are some negative consequences of that. Often people hate them. And if they want, people to like them, that's going to get in the way. Um, people who think they're God's gift to humanity, and there's no empirical evidence to support it because they don't act out of a very good set of values and relational values. Okay. So rating the self low, really low, or rating the self high. And sometimes if you're just in the rating game, sometimes you'll rate yourself really high, sometimes really low. We like just give up the rating game and just focus on evaluating your performance within your particular roles. Performance would be behaviors. Okay. So that can be very, very helpful. And I've had clients even come back into therapy and they'll pull this out of their wallet and they'll say, see, Dr. Johnson, I use it and this has been really, really, really helpful for me. Okay. So homework, and then we'll call it a day. At the end of every session, we collaborate with the client to develop homework, and we try to make the homework more behavioral than we do cognitive restructuring. We may do some cognitive restructuring, but really want behavioral because it's easier to measure progress with respect to behaviors, right? Behaviors in terms of our therapy goals, than if we do some more cognitive things. Lisa Najavitz, who is who created Seeking Safety, which is the one model that is evidence-based for the treatment of both PTSD and other trauma-related disorders, as well as addictions, particularly substance use disorder. It is evidence-based for treating both. It is the one model that is for both. Other times, other models are helpful, but we have to combine models. That one is good for both of them, and it's an excellent model. She doesn't call it homework because she says for a lot of people who didn't do great in school or didn't like school, it brings up some connotations that aren't really good. So she says it's a commitment. Together, as a client and as a therapist, we will commit to trying to get this behavioral change, right? And we will discuss ways that I can help and what they will do to help do that. Okay. So, in session, we may do cognitive, we may do emotive, and even we will do those outside, but best if we kind of focus on the behavioral goals. Okay. Any questions whatsoever about any of that? Okay. Then, if no questions, then I will send out a notice that will come up in my behavioral in my YouTube channel. And so, as I said at the end today, I would give you a way to get the first workshop that I did, first webinar, and it's scrolling right now. If you want free videos on REBT, just go to my YouTube channel, which is called Psychotherapy Education and Training. There are several hundred of them. Some of them are live sessions that have been recorded. Some of them are sessions that have been recorded and someone used identification of the parts of REBT. So for example, they'll say Dr. Johnson is trying to obtain the critical activating event. He's going after the C, the emotion and behavior. He's now doing an inference chain. He's identified the dysfunctional belief or the inference, right? And so they'll go through and label that, which is, the students tell me that's very helpful. And then also they get to see me. There's several that are called the Friday Night Live, which is where we would have volunteers come up. This is in New York City. We have volunteers come up, and I do an example of live therapy with somebody I didn't know. Those are recorded, some of them, and are put on this channel so you can see that from people I didn't even know. And I'm in front of 150 people, and what I do if I make a mistake and all those kinds of things. Because we're going to make mistakes all the time. We just want to get over awfulizing about the mistakes that we make. Well, thank you guys so much. Have a great day, and I look forward to seeing you guys next week. Bye bye.